Hi there, good morning. We're here in April, and my name is Gerard Greene. I'm a male pelvic health physiotherapist in Birmingham in the West Midlands of the UK. And one of my particularly interests in male pelvic health physiotherapy is seeing men with the really tough condition of hard flaccid syndrome. And it gives me great pleasure this morning to speak to my esteemed colleague and male pelvic health physiotherapist, Mr. Adrian Wagstaff. Adrian is based in Reading, which is just outside London. And Adrian also sees, a bit like myself, a huge number of hard flaccid patients, both from the UK and from abroad. And what we're currently doing because of the COVID-19 crisis or pandemic is seeing lots of these men online. So we're quite keen to let them know that help is still there. So Adrian, a really big thanks for turning up. We're doing this first thing in the morning, so I'm glad you're still not in your pajamas. And just to kick off, can you just tell us, how do these hard flaccid patients present to you? What are they complaining of?
Yeah, well, good morning, mate. How you doing? I hope you're well. These hard flaccid patients, well, as we've talked about many times, these guys turned up at the clinic a few years ago now, and you know, that they'd come in with not always your atypical, it would not always be the typical pelvic pain presentation. They'd come in and say, look, I've got a problem with my chat, with my penis. You know, it's a different shape. It's mal-shaped. You know, it's thinner at the bottom. It feels, you know, rubbery in texture. It's kind of hard yet in a flaccid state. I can't get a full erection, or I can get an erection, but it doesn't last as long. It goes away really quick. A few times, not that often, they'll say, I've got changes in sensation, either in, you know, the sort of the shaft of the penis or in the glans, which is at the end. Or they may have a little bit of change in sensation, you know, around their testicles. They'd sometimes present with, and I think increasingly as time goes on, when they've had the condition for a long time, they tend to present then with you know, more classic pelvic pain symptoms. They might have pain. They might have pain down the shaft of the penis, the end of the penis, a bit like pudendal neuralgia, or tension or tightness in the perineum, or they might have issues with voiding. So they might have hesitancy. They might have a feeling they haven't fully emptied. So I'd say those are the typical sort of presentations.
Yeah, that's really good. And I think just to add to that, I think some common things that I see is that they will complain of penile retraction. So penile retraction is really that they will feel that the penis is really shortened. It's lost length. They'll feel it's kind of transiently drawn up into the body. As you said, they complain of this kind of rubbery type penis when it's in a flaccid state. They also complain really of this disconnect, that they feel they're not getting these spontaneous erections. They're not getting morning erections. So those morning erections or housekeeping erections probably nocturnally aren't happening either. And the other thing is that a lot of them can still get an erection, but it's not 100%. So, you know, we as men, we know what our erection is like, but some of them will say, well, it's maybe 70, 80%. It's a little bit fuller on the right, full on the left, but it's changed, and it's definitely changed. Right, Adrian. What are men saying to you that's maybe led to this condition? So what's happened, or what leads to this? Are these men telling you?
Well, I think the by and large, the most common most common cause for symptoms is microtrauma. So this would be you know, doing something called jelqing, which is where they get their penis and they stretch it in lots of different directions. Some guys do this to more of an extreme level, which, you know, maybe some form of sex game or something, where they attach something to their penis like a strap, and then they give it a good stretch. They also use you know, various devices, a bit like your iMedicare pumps and that, but these are not for erectile dysfunction necessarily. They might use they might use some form of penis enlargement kind of contraption. I've also seen chaps that have been on online sort of sex rooms where they've sort of masturbated for hours. So again, a lot of it points to trauma, you know, microtrauma, or like an overuse syndrome where they've just used that they've engaged in some form of sexual activity, overstimulated, but for a really exhaustive length of time.
Yeah, and I think also, just to add to that, we also see, I see probably a lot of, you know, hard flaccid is a young man's condition, you know, a little bit like yourself and I, Adrian, we must be early 30s now. So hard flaccid tends to be, you know, late teens, mid 30s. You see older men with it, but it's generally a younger man's condition. You can see some of them who maybe mightn't have had that specific trauma, but they've maybe been working intensively in the gym, lifting big, heavy weights, really push that. See that. Also, there may have been one or two big stressful life events, such as, you know, a really tough relationship end, a marriage breaking down, financial problems. And I think, you know, at the minute, both of us are seeing a lot of hard flaccid patients. And I do think that, you know, COVID-19 is also a factor. You know, none of us have probably dealt with something of the enormity of this. So it's kind of also fueling these conditions. And also, we know that if people are at home all the time and maybe they're off work, you know, people are masturbating more. You know, it's a known fact. And also people are probably having, if there are issues around that, it's probably that time on their own is probably highlighting, well, maybe it's time to get this sorted out.
Yeah, I think so. And as you alluded to before, just going back a point, you said it is a young man's condition. Absolutely. More, you know, 90% of the cases that come in are younger guys, but you do see it in older chaps. And again, it is, I do wonder if this condition can come on in a later stage with pelvic pain, particularly if they've had, you know, disuse of their penis for a long time, if they've had a prolonged situation with erectile dysfunction. And they'll sort of say in passing, they say, well, do you know what? I've also noticed some retraction, or I've noticed that my penis is a bit harder. But because they've had all the erectile dysfunction and the pelvic pain for many years before this, they haven't really highlighted this as a new condition, but it certainly does, you know, indicate that there are some changes that take place as a more chronic manifestation of pelvic pain, perhaps. But that's only clinical observation.
Yeah, and I think, you know, whether it was a little bit of naivety, but, you know, when I was growing up in Catholic Ireland in the late 70s, 80s and 90s, I don't think we had any jelking there. But I think what you know, especially the guys late teens, early 20s, you know, you say to them, what brought this on? And, you know, not them all, obviously, but a good number will say, well, have you heard of jelking? I was jelking. So, and I think I think I'm happy to say that, you know, jelking is not good for the penile tissues. Attaching weights and straps and pressure bands to it to stretch it. Guys, think twice. We know it doesn't work. It doesn't add to length. Now, Adrian, we've talked a bit about that the penis changes, that there is erectile changes. Do you want to tell us just very briefly, maybe, what's actually going on here? Maybe what do we think is going on in the tissue?
Well, I think, like anything, as you said to you before, you know, this tissue may not stretch all that well. And I think in terms of what jelking is attempting to do is to try and achieve change over a short period of time, a very acute change. And that's not going to happen. We know that because if you consider that the base of the penile muscle, penis is skeletal muscle, and as you go through the penis, it becomes smooth muscle. And what we know with erection is you've got your influx, you know, you've got your dilation of your blood vessels during an erection, which is neurologically driven, you know, through arousal, through changes of emotion and feeling, and that engorges the erectile tissue. It fills it up, it swells up, And as that happens, the pressure down on the veins increases, and that kind of prevents the majority of the blood escaping from the penis. Now, if you've subjected any part of your body or any area of your body to extreme stretch, we know that what happens in the muscle, the basic understanding, you know, and that process is disrupted either because you get microtrauma to the tissue. Whether you get microtrauma to the actual blood vessels is I suppose, is more theoretical. I haven't seen a huge amount of evidence or clinical evidence.
I think you do. I think you do. Like
in terms of, but no. My point being, I'd suggest that you perhaps do.
Oh yeah.
From a microtrauma perspective, and then of course you don't get the normal feedback loop. So the penis doesn't empty properly because perhaps part of the erectile tissue doesn't disengage, or the part of your muscle doesn't disengage, or you might end up with changes in the blood vessels, so they can't empty.
Yeah, and I think also, I think a lot of men will maybe leave it quite a while before getting treatment for no fault of their own. It's, you know, not a lot of people know about this. So then they also get secondary changes around the hips. They get muscle shortening in the hips, in the psoas muscle, in the adductor muscles, the hamstrings. They get a lot of secondary tightness in the fascia, in some of those fascial slings. I think that contributes because that feeds into the pelvic floor. We know from some of the anatomy work we've looked at in the dissection labs, the pelvic floor, the penile tissue is integrated within that fascial network. So that tends to be a factor. There is a lot of pelvic floor dysfunction. The pelvic floor tends to be maybe not working very well. And maybe a little bit working too much. So it's not allowing that normal erectile function, and also allowing that erectile relaxation in that a lot of men that feel that they have that tightness afterwards. And I think I like to, a lot of us are watching a lot of Netflix at the minute, and, you know, a lot of us have watched Tigerland, and, you know, we like Joe Exotica, but, you know, Joe Exotica looks a really stressed out guy. Well, I think I haven't finished it yet, but I hear he's in prison. But, you know, if you've been chased by lots of tigers, you've got lots of stress in your life, that drives a lot of adrenaline. We know that adrenaline is not good for the reproductive tissues. So we know that a chronically stressed state is not good for reproduction. It's not good for bowel. It's not good for bladder. So that contributes to real problems with hard flaccid. And I do think there's without getting too technical here, at 8 o'clock in the morning, it's like almost like a sympathetically driven condition. But we can delve into that maybe in another podcast. And so I think the whole stress and anxiety, which this condition cause, kind of almost feeds that.
I think so, and you know, like you say, the stress and the anxiety, and that's a really key point to trying to understand how to manage it. If you understand that, you know, whilst even the stress, I mean, not that necessarily they're stressed and they wake up the next day with a condition, but stress actually drives.
Otherwise, we'd all have it, Adrian.
Exactly.
Especially at the moment.
You know, it drives behaviour. It changes behaviour, and I think my point being saying, you know, my point before saying about, you know, not just purely a vascular, you know, blood, a problem with their circulatory system or blood or vascular, because you don't get the cardinal signs and symptoms that you would with a vascular type problem. You know, you're not getting the sort of the extreme. It's not, pain isn't necessarily their primary complaint. It's
very much the penile erectile change. Okay, Adrian, do you want to give us a few key things that you focus on in the assessment, whether that's in the clinic and also maybe what we're doing now online? So what are some of the key things? Because I think there's a lot of myths out there about what we as male pelvic health specialists do.
Well, I think online or face-to-face, the first and foremost, I mean, I've sometimes spent a couple of hours with these chaps, and if they're traveling from quite far, I often suggest we have a 2-hour session. And that's because for the first hour, sometimes hour and a half, you can just be chatting. you know, you can get so much information. They actually, generally speaking, they've been to see their GP. They've, you know, pretty much 98% of them have been to see a urologist, or sometimes 2 urologists, and they haven't been able to discuss their problem with anybody. They just get the shoulder shrug and say, well, it's probably all in your head. So they've got so much information to tell you, and they really want to tell their story. And, you know, storytelling is so important. And I always remember, you know, I think Bill Taylor once saying, one of his old gaffers saying, if you ask the patient enough questions, he'll tell you how to treat him. And you know, I think it's the same as you and I have both been through the MACP training, and it really hones your communication skills. And these guys have got such sensitive and very private conditions that communication is key. And I think online certainly helps facilitate that, because one, as a clinician, you can observe yourself, you can see, you get a bit of feedback about what you're doing, what your facial expressions are you being, you know, is your empathy, you know, sufficient, is it there? And also looking at the patient, and you've also got time to really focus on your questioning, and being, you know, that history part is really essential, differential questioning. So if they have got problems with voiding, you can talk about behavior. Is it hesitancy? Is it retention? How long they can keep an erection for? What's their history? You know, what were they doing at the time? What was their lifestyle like? And all of those things really help build a character, and that can help you understand how you're going to manage this patient, so that when you get to thinking about planning for treatment, you've got a really awesome picture, which should happen with every one of your patients, because if they've sprained an ankle, you want to know how motivated they're going to be to actually do some rehab.
Exactly. And I think, and I think, yes, that's all. That's you know, I think what you're saying there are the key points in a really good assessment. And I think what we will also do is we will look at how they're moving. We will look at the lumbar spine. We will take a good look at the hips, the pelvis. We will look at a lot of muscle length. We're looking for shortening, any shortening of the fascial tissues, any shortening of the psoas, the big hip adductor muscles. We will also look at pelvic floor function. I think we're both in a fortunate position. We do a lot of diagnostic ultrasound. So I think the guys like that, because you know, all you do is you put an ultrasound probe, lower tummy, and that is a really non-invasive way of looking at, well, what is the pelvic floor doing? Is it doing too much, too little? And also, people get these problems. A lot of the guys say, well, my problem is when I can't get an erection when I'm standing, or I'm getting more symptoms when I'm doing stuff. So with the ultrasound, we can look at that. We put it on, and we can look at what those pelvic floor muscles are doing.
Absolutely. And I think from an online perspective, both you and I have done so much ultrasound on patients. We've really got a good understanding about, you know, you can almost sense what's going to be in the pelvic floor, you know, the timing of their pelvic floor, just by doing your external palpation, looking at what their diaphragm's doing, so observing their abdominal breathing. And I think it's really important what you just said then about, you know, muscles, connections, fascial connections. And there's a lot of, you know, we tend to bash posture quite a lot, but for many of these chaps, they come in with posture as being such a fixation about their condition. And what I generally do is I don't tend to focus on that. So I won't correct them and go, oh no, that's a big myth, you know, and waste time doing that. I'll sort of appreciate that they've got the fixation on their posture, and I don't think that's such a bad thing as a way in, as a buy-in to chat to these guys, because you can help them facilitate their functional improvement. And if you do that, if you correct all these muscular imbalances or strength deficits, you will make a change in their condition, because cognitively, emotionally, they'll feel a lot better. Yeah,
and I think, you know, I had a couple of patients yesterday with hard flaccid, and you know, if you have hard flaccid and you're seeing someone, if they're not asking you, about masturbation, if they're not asking you about sexual activity, if they're not asking you about your penis, it may be time to look elsewhere, because it's a bit like if I go in and I've got a hip problem to someone, you know, I'd kind of expect them to ask me about my hip. I expect them to look at my hip and ask me that. So I think that, you know, it's we need to be asking these questions. And the men, when someone finally asks them about it, you see the shoulders drop. Weight comes off their shoulders. Okay, Adrian. So what are some key things? Maybe we know we do a lot with these men, but what are some of the key things that we do in terms of their treatment?
Yeah, so I don't think, I mean, sometimes talk about sort of mindfulness and relaxation, and when you've got a fairly alpha male in front of you with this condition, that doesn't always wash that well. So again, I tend to focus on functional components. So pretty much, you know, looking at abdomen, their breathing. And why that's important? Well, if you get someone to belly breathe, if you get them to lay on their back, breathe, take deep breaths in, take slow breaths, it kind of relaxes them, it chills them out.
Hugely. I think we might have just lost Adrian there for a minute. So I'll just take over, and in terms of the treatment, Adrian talked about the importance of relaxation. And I think what I use a lot is headspace. Headspace is good. You try and do it about 10 minutes a day. And sometimes people will say, well, I haven't got 10 minutes a day. That's really a sign that people need to be doing that. The belly breathing is really important. The belly breathing is important because that really gets some movement through that pelvic floor. And Adrian is back. Adrian, I just kind of took over from you for a second there. So I've talked about the importance of the belly breathing in getting the pelvic floor moving, and also that sometimes the headspace is good in terms of getting that kind of mindfulness relaxation. So do you want to just carry on from there? So I hope you weren't sneaking out there for a slice of toast or something. So you carry on in terms of what are some key things you would do in the treatment?
Yeah, so absolutely. If you've done the belly breathing, that's awesome. The other thing is, you know, so I tend to start off with functional stuff. Not every time, but that's probably one of the key things I do. So if we consider that most of the time the pelvic floor doesn't move all that well, and you know that they're not able to kegel all that well, they're not able to do a reverse kegel, which is the opposite, like you're trying to break wind. So I generally don't focus on those, and quite often these chaps have come in and they've tried to do lots and lots of kegels anyway, and that's often exacerbated or even initiated their condition. So lumbar spine stretches, as we alluded to before, hip stretches, looking at their gluteal function, so perhaps giving them bridges, and also teaching them to, as I said before, not to give them pelvic floor contractions, but looking at whether they can engage their pelvic floor, so they know how to relax from it, and they can sense whether they are contracted or not, or over contraction. And what I mean by contraction, I don't mean they're constantly tensed up, because if they were, they'd probably have more profound or more typical pelvic floor symptoms. But given in that sense that, you know, can I lie down? Can I contract, and then can I feel myself fully disengage? As Joe Melios would say, you know, for prostate patients, can they lift their nuts to their guts? You know, as a good prompt for pelvic floor. Can they drop it? Can they drop themselves down? Can they drop themselves away from that position as well? So that's really important. And as we said before about looking at function, you know, can we give them exercises which, you know, focus on lateral hip rotators, bridge, you know, even a squat, where they're engaging big muscle groups whilst not exacerbating their pelvic floor symptoms or over tension in their pelvic floor.
Yeah, and I think I think sometimes it's good to give people a couple of things to focus on rather than throwing lots at them. So I'm very much get them to do a few things properly, build on that. We progress to doing reverse kegels, which is a very gentle kind of relaxation of the pelvic floor. I think it's good to get them doing some dynamic stretching, almost kind of a specialized type of stretching, almost incorporating a bit of maybe eccentric activity to really around those hip flexors, adductors, hamstring muscles, because we know they're connected to the fascial system in the pelvic floor. Also, getting them active. You know, a lot of these men will say, well, I used to go to the gym. I used to run. I used to do exercise. Now I've stopped. I'm afraid. I feel it'll make it worse. So we kind of get them, probably about 2 years ago, I had quite a decent level triathlete, and he had stopped doing everything really. And we got him back walking in the pool. And then he got back swimming, and then he got back walking. So getting them back doing some exercise. Squatty potty is good for, if a lot of people say, well, when I do a bowel movement, I get more penile retraction. Squatty potty is good. Sorry, Adrian, come back in there.
No, it's all. I think that's all absolutely top stuff. And as you were saying, about doing exercise where you're graduating their exposure to to various activities, and then you're grading that exposure as well. And when you think about returning to sexual activities, a lot of these chaps have completely disengaged from sex, masturbation or intercourse, penetrative sex, and it's about talking to them with the sensitivity to get them back to doing some form of sexual activation without exacerbating their symptoms, because most of the time they're petrified, or they might get pain or a real aggravation of their problem if they engage in any form of sex. So saying to them, like, maybe like you would if you're teaching someone to go back for a run, to get them back into a run, sort of, you walk for 5 minutes, run for 5 minutes or something. You're doing the same here. You're saying, look, don't start to engage with sex. If it doesn't happen, then leave it. Leave it alone. Do something else.
Yeah.
And don't try and keep flogging it. Don't try and keep pushing it for as long as you can, because you will just make your symptoms worse.
And I think also it's these are young men. These are young men, And I think one thing that I've always remembered from my dear friend and world-renowned pelvic health physio Joe Milios is that when I've been fortunate enough to listen to Joe speak a lot, and Joe emphasizes that erectile dysfunction in young men is a very big problem. Probably 10-15 years ago, erectile dysfunction was kind of associated with men probably more kind of your age, Adrian. Actually, a lot bit older than you, Adrian.
Older than me.
Whereas now, erectile dysfunction is a big problem for men in their 20s. And I think getting those men back to sexual activity, it's also trying to de-emphasize the penetrative component. I think a lot of, especially younger men, will think that sex is all about penetration. When you speak to the older men, probably the post-prostatectomy men, they have lived a bit, they have more experience, they can see that sex is much more about that. So it's trying to move them away, that especially getting back, and especially if premature ejaculation is an issue, that it's more about that kind of gradual build up, that sense, that sensuality of touch. I think Constantinus, my colleague, we did a great session with a patient. It's probably last year, that he had real fear avoidance about masturbation, and then he wouldn't engage in sexual activity with someone until he was happy masturbated. And Constantinus and I sat him down, had a really kind of relaxed chat with him, and we said, okay, what we want you to do is, you get in the bath, put some nice music on, just relax, do some belly breathing, then do some very kind of gentle stimulation. He came back in a few weeks later. He was a changed man. it was, I must admit, I'm almost a bit emotional speaking about it now, but that was powerful for me and Constantinos. And now he's back in a really happy relationship with his partner. Right, that gets us on to, I'm just going to check the questions here. So we put out a call for questions on, particularly to patients. We wanted to hear from real men with heart flaccid. So we put out a call on some of the groups on Facebook, and those groups do really great work. As you know, that's kind of the only place the men can get support. So, Adrian, I'll throw one at you here now that you've finished your toast. So, a couple of people have messaged you saying, "Well, am I the only person with this?"
Definitely not. I mean, we know that there's a large percentage of people that won't come to us for many a year. I've seen guys with this condition that panic, see their GP, have a fast track urology session, and then come and see us within a matter of weeks. And then I see guys with this condition who've had it for 5 or 6 years, sometimes longer. And they're definitely not the only one with this. You know, the number of patients I've seen now. I know I wrote a blog last year, the start of last year. You know, and at the top of it saying I've treated over 75 cases of this now, of hard flaccid as a condition, and I'm well into the hundreds. And you know, that's how common it is. Yeah. And it's amazing. Where I used to see this once a month, I'm now getting patients with it 3 and 4 times a week as a new patient present.
And I think I see that as a real positive. You know, I think getting back to Joe's work, it's getting the message across that help is there, whether that's for hard flaccid, whether that's for men with male pelvic pain, help is there, whether that's the men who've had post-prostatectomy, urinary incontinence. Specialist male pelvic physiotherapy is there, and it can help them. I'll take the next question. The next question is, it kind of fits in really with the first one, is that there is a real frustration is, you know, why does no one know about this? You know, most of the men I see, most of the men you see, most of the men Joe or other esteemed colleagues, Bill Taylor see, they will say, well, I only found out about this on Facebook, or I only found out about this through a forum, or I only found out this by Googling extensively. And I think that's a frustration we share. But I think the urologists are, you know, highly specialized in conditions such as prostate cancer, bladder cancer, other kind of, you know, really serious conditions, which, and, you know, I know this is a subject dear to your heart, Adrian, as you've been through this yourself, but thankfully you're coming out the other end. So I think the urologist's concerns are those really conditions where there is something kind of, you know, wrong with that bladder, with that urinary system. And I think it's the awareness of pelvic pain is not great in men. The pelvic pain men do not get a great deal, but I think the hard flaccid condition falls even lower. But hopefully, you know, I think this is changing, but it's changing very slowly. The other question then, which I'll take, is, are kegels bad? So a kegel is where you do a pelvic floor contraction. Kegels are not great for hard flaccid, especially in the initial days, for 2 reasons. One, men struggle to do them properly. They tend to go a bit crazy with them. And a lot of the young guys are doing them because they feel a bit like the jelking. They feel it'll help their sexual performance. But they're going crazy with these. They're not doing them properly. And also, a young male pelvic floor does not tend to be weak. The people that we need to strengthen are the older men who've had prostate surgery, but it's not that they're weak either. Their pelvic floor just needs to work much stronger because it's got to compensate for the lack of a prostate and the lack of the automatic sphincter. So younger men should not be needing to do kegels, and it tends to make things worse. And it also tends to bring on a lot of the symptoms.
I'd agree there. And as we said before about using the diagnostic ultrasound when we are able to in clinic, it has really helped with the teaching of a Kegel, because you can really help a patient to plan the phases of the contraction. And as you said before, sometimes if they do present on the occasions where they present with urinary symptoms, then I think Kegels are perfectly useful. You're quite right. If you give them to hard flaccid patients, it does make them worse, and we know that from trying it. It doesn't help at all. And if you teach them incorrectly, or if you don't say to them, you don't give them really specific parameters on when to use them, like you say, they will go for their life in trying to thinking this is a really good contraction, a good exercise for me, and this is really going to help me. So yeah, absolutely.
Then I suppose the next question, as you can expect, Adrian, I'm picking all the easy ones for myself, and I'm throwing you the really tough ones. Okay, I think this is another really good one. Is why does stress and anxiety, why does that make it worse? And we've kind of touched on that with the kind of Joe Exotic example, but for the patients, maybe in a couple of sentences, why does that make it worse?
Well, I think the concern and worry. So the shortening, you see your penis is mal-shaped. It might be bent to one side. It might be thin at the bottom, thick in the middle, thin at the top. It's mal-shaped. That's going to cause you a huge amount of stress and anxiety. If you've done something to yourself, you may think you've broken your penis in some way or damaged it permanently, particularly if you've got sensation loss. But also, the functionality of it, the appearance of it, how people are going to view you if you're a young chap and you're engaged in regular, sexual activities, either with a new partner or a different partner. There's going to be that self-consciousness that's going to occur, like you would with any sort of body, dysmorphia type behavior. And I think certainly, as we said before, once you get adrenaline pumping in your system, once you get, that doesn't have a particularly good effect on your erectile function, on your cognitive. So, if you're worried or stressed in a situation, you're not going to be best placed when you're engaging in sex. The moment you start worrying about having erectile dysfunction or having deformity in your penis, we know how the brain works with pain. Your brain will play that out. It will play that.
Yeah.
Potentially, we don't know enough about hard flaccid to say exactly how that functions, but there's clear neurological, cognitive drive for this condition, and that is as a result of stress.
Yeah, and I think also a little bit like the pelvic pain patients, and they are different, is that commonly we see that someone's symptoms may be associated with the breakdown of one relationship. Those men want to get back maybe in the dating game. I feel like really old when I say the dating game. They want to get back, they want to get out there, they want to find maybe a new partner, but that becomes difficult because there's that anxiety, that concern that if they find a new partner, that they may have these erectile issues. So they're really stuck. It's quite difficult for them to move on, both physically and emotionally. Right, Adrian. We've just got one, and I'd like to say a big thanks to the patients out there, because lots of patients sent us really great questions and really helped kind of structure this podcast. And I'd like to thank especially the groups on Facebook who were very supportive in that they allowed us to put a call out for questions. And it's thanks to all those men that we're doing this. So a big thanks thanks to them. And also the people who run those groups and facilitate those groups. You know, I run a couple of Facebook groups myself, and, you know, it is not an easy job. So thank you to those facilitators. You do amazing work. And really, without you, men would have less help and support. And this is also something that's kind of very dear to my heart, is that it's very frustrating that this is a condition that does well. The patients do well because generally the patients are fit and healthy. Well, they don't have lots of other conditions. They're young men. The patients do well when they get treatment, but it's very difficult for the patients to find anyone to treat them. And, you know, I think my hope and Adrian's hope is that one day, you know, every kind of small community, every small town would have a physio who could treat hard flaccid. And you know, and I think that's my kind of goal really, or that's my hope really, that, you know, every small town would have a male pelvic health physio, or hopefully a couple of them. But that's not the case at the minute, which is frustrating for us as well. So, Adrian, how does someone find a physio who'll treat hard flaccid?
Type into Google.
Yeah, and in all seriousness, Google. I think Google is a really good starting place, because Google will find you someone who can treat this. Hopefully.
I think what's important is its ownership on the health practitioner, that they need to ensure that their website and is informative and has sufficient content, so that when it is indexed on a search engine like Google, that the information does pop up and guys can engage with it. With that, we've really got to make sure the information and content that we put on there is relevant and the best available evidence that we've got. But for chaps, I think, you know, certainly chatting to a pelvic floor therapist, and I think it's really important that what we do, we spend a lot of time, and you very much so, Gerard, is spending time networking with other practices and other clinics, so that when guys go into a practice and they say, hey, you know, I've got this sprained ankle, but I've also got this other problem as well, and they feel confident that they can talk about it to the male or female women's health specialist, if it's a women's health specialist, and they then turn around and say, well, actually, I can't help you with this, but I've got a really good colleague that's, you know, in the next town or something, or down the road, and it's having that really important network so that the information is made available. So you're quite right. A lot of these guys go in search of these answers to their condition on forums, and they haven't always got the best available evidence. So it's quite important that healthcare practitioners make themselves known, make themselves aware, really promote themselves, and push all of their key information out into the public domain.
And I think it's also really like these, you know, testicular, penile symptoms, urinary symptoms, bowel symptoms. These, you also need to really think, well, who am I seeing for this? You know, what qualifications do they have? Because although we are concerned with hard flaccid, what we initially do is quite a detailed screening to make sure, well, you know, does this patient need to urgently see a urologist? Do they need to see a colorectal specialist?
Yeah. Do
they need to see a sexual medicine specialist? So I think what men in particular are not great at valuing their health. You know, I'll speak to myself about that as well, possibly. Men tend to put off things as long as they can. But, you know, if you're entrusting yourself to someone, it's good to do a bit of checking. Well, you know, does this person, do they have a recognized qualification? Do they have some specialist training? Am I confident that if I go and see them, they will be able to make the decision, is it within their scope of practice to treat me, or do they need to refer me to one of their medical colleagues? Or am I happy that if it's not within their scope of treatment, will they refer me to someone else? I think that's really important. And I think I think both of us will admit these are not easy conditions to treat. You know, male pelvic health, like female pelvic health, is complex. There is a lot going on. And I think what gives me a lot of confidence that with a lot of the patients who come and see me for heart flaccid is, you know, I have my brilliant colleague, Lisa, who is not actually beside me on the sofa because that would just be a bit odd as it's 8 o'clock in the morning. But, you know, Lisa's like my work wife and I think I'm like her work husband. So Lisa and we speak about a lot of the patients. She sees a lot of them. I see a lot of them. But what we also do is we ring Adrian. So, you know, Adrian and I have like a catch up once a week. We have that in our diaries once a week. And who do we discuss? A lot of the heart flaccid patients because they're complex. So it's good to, you know, to have that support. So it's a bit like I feel if a patient's coming to see me, well, actually they're seeing me or they might be seeing Lisa, but we've also got Adrian's expertise in the background. You know, we open the cupboard and pull Adrian out. And then if they're seeing Adrian, like the patients are confident, well, they know that Adrian has got a support network of just to discuss these patients as well. Adrian, before we finish up, because we've both got patients in 10 minutes, Adrian's off for more toast, I think.
Yes,
so Adrian, is there anything you'd like to add before we finish?
Yeah. Oh.
Anything you'd like to add in there, Adrian?
Hang on. Over
Yep,
there.
he's back in the room.
I'm back in the room. No, I think that's
yeah, we've covered a lot.
Comprehensive, to be fair, from what we said, and like you said before, this is a treatable condition. I think what's really important, and as you said before about, you know, making sure that you see someone that's experienced, and, you know, you and I have been in the game, you know, 20 years plus, and it's, you know, understanding how, you know, how patients function, how conditions, and how you've got to give things time and give patients a specific plan is really, really important, and not expect the condition to have ups and downs. It's not going to be a straight line of recovery. It is going to be up and down, as long as you help people to, you know, sort of dance around that sort of, you know, a progression, whether it be, you know, being up and down, and the fact that, you know, it's really important to highlight to people, to patients, that their condition will be up and down, and they will find that some things one day will aggravate it, and another day that they won't, like a lot of other conditions. But it is, as you said before, it's so important to engage with someone that's got specialist knowledge, and I think we're very fortunate, because having experienced a lot of pelvic pain patients over the years, you know, we sort of, it's not too daunting to treat this condition anymore. I think in the early days it was quite a worry to see these chaps, because we didn't really understand what was happening, and nobody appeared to have any of the answers.
Yeah, so thank you for that, Adrian. Thank you for taking time out from I know you're a busy man, you've got 3 young kids. So like myself, you know, we're balancing kind of looking after the kids at home, doing a bit of homeschooling. You've got a busy online clinic. I know you've got patients now in about 7 minutes time. And I think also, I suppose, on behalf of both of us, it's the Friday, I think it's the 24th of April. And we're in the middle of COVID-19. So, you know, our thoughts are with you all, because no matter whether you're here in the UK, Ireland, wherever, we're being affected by COVID-19. So I hope you find the video beneficial. Apologies for the glitch in the middle, but I suppose we are male pelvic health physios. We're not tech gurus. We treat patients. We don't do a lot of IT stuff. So bear with us on that one, and stay safe in COVID-19. And Adrian, I'm just going to finish this. And Adrian, once again, thank you very much. Just bear with me for a second, Adrian.